Hey everyone, and welcome to The Explainer. Today, we're unpacking a truly monumental piece of research, one that is seriously challenging how we think about one of the most common medical treatments prescribed in hospitals today. We're going to do a deep dive into a highly detailed, deeply fascinating study by Dr. George Doumat and his colleagues, which was published in the Annals of Internal Medicine in April 2026. This isn't just another clinical paper. It's a massive look at how real-world medicine so often clashes with idealized clinical guidelines. So let's get right into it. Okay, let's dive into this. Here is our roadmap for making sense of this massive dataset. 1. The antibiotic duration dilemma. 2. Emulating a target trial. 3. The 10% catch. 4. Comparing patient outcomes. And 5. What about everyone else?
All right, part 1. The antibiotic duration dilemma. To really grasp the gravity of this study, we first need to set up the medical baseline and the core conflict that doctors face literally every single day. And that is, how long should we really prescribe antibiotics for pneumonia? I mean, it seems like a straightforward question, right? You get sick, you take the pills until they're gone. But for decades, the medical community has debated this exact timeline. Longer courses might ensure the bug is dead, sure, but they drastically increase the risk of adverse side effects and fuel global antibiotic resistance. Shorter courses might be safer overall, but are they actually as effective at curing the infection? And to understand the high stakes here, we have to look specifically at community-acquired pneumonia, or CAP. Based on foundational research by Ramirez and colleagues, CAP is the single most common infectious cause of hospitalization in the United States. And it is incredibly serious. It carries a 6.5% mortality rate during hospitalization. We're talking about a major public health issue here, where getting the treatment duration right is literally a matter of life and death. Recently, though, the medical establishment made a major shift on this. The 2025 American Thoracic Society guidelines explicitly state for adult inpatients with non-severe CACP who reach clinical stability, we suggest less than 5 days of antibiotics rather than 5 or more days. Now, this updated guidance didn't just come out of nowhere. It was heavily influenced by a major 2021 study called the Pneumonia Short Treatment Randomized Trial, and that really firmly set the expectation that shorter courses are the way to go. Let's move to section 2 and see how this builds. Emulating a target trial. Moving from those pristine clinical guidelines into the messy, complicated world of actual hospital data, Doumat and his team didn't just run a small, isolated trial. They tapped into data from the Hospital Medicine Safety Consortium, or the HMS. This is a data set of massive scale and reliability. It encompasses 67 different hospitals across Michigan, tracking incredibly detailed patient records from 2017 all the way through 2024. So we are looking at a huge, rigorous, real-world sample. But, how do you test a treatment using past observational data without introducing a ton of bias? Well, the researchers used this absolutely brilliant methodology called a target trial emulation. First, they identified the hospitalized CAP patients. Second, they ensured these patients achieved clinical stability by hospital day 3. And third, and this is the genius part, they created statistical clones of these patients. They assigned one clone to a short duration of antibiotics and the other to a long duration. This statistical cloning effectively mimics a randomized trial using real-world observational data, completely eliminating selection bias and allowing us to see a true apples-to-apples comparison of the outcomes. Which brings us to part 3, the 10% catch. All right, stepping into the data funnel phase of our explainer, and frankly, this is a major twist in the narrative of this study. 55,517. That is our starting number. Over 55,000 hospitalized patients with community-acquired pneumonia across these 67 hospitals. This massive number represents the real, complex reality of the healthcare system. You'd think a huge chunk of these patients would be prime candidates for that short 3-day antibiotic course the guidelines so enthusiastically recommend, right? Well, pulling directly from figure 1 of the study, the researchers had to apply the exact same strict exclusion criteria that were used in that original 2021 clinical trial, the one that changed the guidelines. And the drop-offs are just staggering. 39.3% were immediately excluded for severe underlying lung disease. Another 12.7% were out because they simply weren't stable by day 3. 11.5% were excluded for receiving empiric MRSA or Pseudomonas therapy. 6% had a beta-lactam allergy. 4.7% had terminal renal failure. The list of exclusions just goes on and on. Now, what's really interesting about this is the jarring final number, 5,620 patients. Out of over 55,000 people, only 10.1% actually met the strict eligibility criteria for the short course therapy. Let that sink in. Almost 90% of real-world patients were disqualified because they were too complex, too sick, or had other confounding factors. The guidelines strongly recommend short courses, but in reality, hardly anyone actually qualifies for them under the trial's original rules.
Let's look at Section 4, Comparing Patient Outcomes.
So let's zoom in on that tiny eligible 10% subset and analyze what happens when we actually compare their medical outcomes. To be totally clear on the parameters of this target trial, researchers compared a short duration, meaning the patient received 0 to 1 additional days of antibiotics after day 3, totaling a 3 to 4 day course. They compared that against a longer duration, which meant 2 or more additional days, bringing the total to 5 or more days.
I want to meticulously walk through Table 2, straight from the source material. We're looking at the adjusted 30-day risk ratios between the two groups. For mortality, the ratio is 0.89. For readmission to the hospital, it's 1.07. Urgent visits, 0.94. And for C. difficile infection, which is a very dangerous intestinal complication linked to antibiotics, the ratio is exactly 1.01. So what does this actually mean? Well, in statistical terms, because these risk ratios hover right around 1.0, it means the outcomes are incredibly similar regardless of duration. For that eligible 10% of patients, a short 3-day course is just as safe and effective as a longer 5+ day course. But here is where human behavior and institutional habits really come into play. Despite the proven safety of the shorter course for these specific, stable patients, only 7.9% of the eligible patients, that's just 444 out of 5,620, actually received the short 3 to 4 day antibiotic course in the real world. Think about that. Even when a patient perfectly fits the criteria for a safer, shorter course of drugs, doctors almost always default to prescribing the longer duration.
Finally, Section 5. What about everyone else? And this brilliantly illustrates the researchers' concluding realization about the vast, vast majority of patients who were excluded from those pristine clinical guidelines. Doumat and his team explicitly state, except for patients who develop severe complications, no trials to our knowledge have found that longer durations of antibiotic therapy are safer for patients with comorbidities. This is a profound statement. 90% of patients were excluded from the short course guidelines because of their complexities. But the researchers realized there's actually no solid proof that longer courses are safer for that excluded group either. We've just been assuming they are.
So the crucial point is this. The study issues a massive call to action. We urgently need pragmatic, real-world data for patients with more severe CAP, those with immunosuppression, multiple comorbidities, or persistent vital sign abnormalities. We literally cannot keep relying on narrow clinical trials that exclude 90% of the very people actually walking through the hospital doors. Which leaves us with a really provocative question. What duration is safely treating the 90% of patients left behind? This study proves that while shorter antibiotic courses work beautifully for a very select few, the vast majority of pneumonia patients are existing in a gray area of medical evidence. It's a powerful reminder of the massive gap between controlled clinical trials and the complex reality of real-world medicine. Thanks for joining me on this explainer, and keep questioning the data.